Hey guys, we're going to talk to you today about evaluation of miscarriages and specifically recurrent miscarriages, although I do want to do a little bit of an explainer on what causes most miscarriages. I'm just going to jump right in here. One of the first things that you should know, and this is something that I tell every single patient who's had a miscarriage, is it's absolutely not your fault. There's nothing that you did that made this happen. And people very frequently will ask me, is it because they went bowling last week, or they went four-wheeling, or they had intercourse, or they took any particular medication? And, virtually always the answer is none of those things. And that's really important to understand, is that it's not something that you did that made this happen. Recurrent miscarriage is really defined as at least 2, and in some textbooks they said 3. So when we start talking about what kind of things actually lead to miscarriage, one of the most common is chromosomal abnormalities, and this explains about half. Let's take a look here at a screenshot that just demonstrates the chromosomes for a second. So when you're thinking about these paired chromosome sets, so you have 22 chromosomes that are paired and numbered from 1 to 22. In each case, one chromosome is from mom. If you can see, that's red. Could be pink. One chromosome is blue. That's for the guy. So most of these chromosomal abnormalities are what we call sporadic. They just happened. They happen more commonly in women over 35, and it has to do with the fact that their chromosomes get more sticky, and something that happens right at the last stages of fertilization, called meiosis II. Normally, there's one last division of chromosomes in the egg as the sperm's kind of coming in there, and typically these paired chromosomes, the last set from the mom goes over to the side of the cell into what's called a bar body, and then as that sperm comes in, now you've got just the normal set of 2. But if that didn't happen, if these 2 from mom didn't separate, that's called a non-disjunctional. That's a non-disjunctional event. And then when the sperm comes in, now you have 3. So that's the most common way that you're going to get, say, trisomy 21, for example. Another example is where you're missing one of these chromosomes, so that's called monosomy. Let's say you just got the one chromosome from mom, that's pink or red this time, but one didn't come from dad. So in this case, you're missing one. That's called monosomy. So monosomy X for the X chromosome, that one is the most common monosomy that we know of, and that's if those babies live, it's called Turner syndrome. But again, it's one of the more common causes of miscarriage, so monosomy X. So you're missing a chromosome. Now, another way, it's a little more complicated, but it can be an explanation for recurrent miscarriage, is when you have what's called a balanced translocation. So that's going to take a little additional surgery here. Hang on a second. For this discussion, we're just going to say that this is a chromosome that is from mom, and this one is also from mom. So for a minute, just ignore the fact that they're pink and blue like mom and dad, and just think of them as chromosome number 21 and chromosome number 16. So just for sake of argument, just keep that in mind. When you start out making sperm or eggs, the chromosomes double, and so you have a matched set. And so you can have a matched set of 21 here and a matched set of 16 there. And then normally they will separate like this and come apart. But sometimes these guys get crossed, and that's where your balanced translocation can happen. And then all of a sudden, part of one chromosome can actually swap with another. And you can see all the information's still there. Then all of a sudden, this is the situation. And now, if this chromosome goes to one egg and this chromosome goes to another, you're missing a piece of your 16 and you have an extra piece of 21. And if it so happens in the same egg that this chromosome goes with it, you now have an extra piece of 21 And when this chromosome separates, it's missing a piece of 21. And then when the sperm comes in, now you have an extra, those are 21s. Now you have an extra 21 piece right there. So it's like a partial trisomy 21. This guy goes somewhere to a different egg. So that's how you wind up with a trisomy in a balanced translocation. When you start talking about other things that you could evaluate for recurrent pregnancy loss, like I said right off the bat, in the isolated pregnancy loss, half of them are chromosomally abnormal and it's just random. But when you start talking about recurrent pregnancy loss, you're more prone to see these kind of things where there's a balanced translocation, and that's going to lead to these types of chromosomal abnormalities, but they're going to happen repetitively. Checking chromosomes for moms and dads sometimes is useful. 4% of the time it's present, then that means 96% of the time it's not. So there must be other things out there that cause pregnancy loss in a repetitive fashion. And another one is what we call antiphospholipid antibodies, or antiphospholipid antibody syndrome. And these are detectable by a blood test. It's not entirely clear why they cause miscarriage. There are several theories, some of which are linked to inflammation, where the actual placental cells implant. There are theories that it could be related to blood clotting disorders. And that's really important to hear too, that a lot of times people come in and they've had blood testing and they found out they were a carrier for, say, factor V or protein C or one of these clotting disorders. That really has not been linked with recurrent pregnancy loss, although for years we thought it was. If I see a patient who's had factor V diagnosed or protein C or S, I tell them it may increase your risk of blood clot a little bit, but there's no evidence it's causing miscarriages. Both of those tests, whether you're talking about chromosomal analysis or antiphospholipid type antibodies, are determined by blood work. So those are sort of standard routine tests we'd recommend. Also, you'd recommend check some basic hormonal things like make sure thyroid's functioning normal, make sure prolactin's functioning normal. These are pituitary hormones that, if out of whack, could contribute. There's no conclusive evidence. There's not been good studies, but they also have other implications for your health, so it makes sense to test them, and if they are abnormal, to correct them. The other big category of sources for recurrent pregnancy loss are abnormalities of the uterus, and there are several different abnormally shaped uterus. The most uteri. The most common is what's called a uterine septum, and basically, I'll put a graphic over here. Basically, this is just a little abnormality within the cavity of the uterus, how it formed, that when a pregnancy implants on that septum, it's not normal tissue and it just can't support the pregnancy, so pregnancy losses are more common in that situation. The good news on that one is they are very often correctable surgically. The way that we test the uterus is with what you call a hysterosalpingogram or HSG, and that's an X-ray, or sonohistogram, which is a SHG. And either way, they're just different imaging tests where you inject either water if it's an ultrasound or contrast dye if it's an X-ray to fill the uterine cavity, and then you can visualize it to see if any of these abnormalities are present. People ask frequently, is there any evidence for infection causing recurrent miscarriage, whether it's chlamydia or mycoplasma or some other bacteria? And the bottom line answer is there's really not. So don't really recommend doing cultures or biopsies of the endometrium to rule that out, because there's just no evidence that treating it makes any difference. Male factors, there are not a ton of male factors beyond if a dad has a balanced translocation, which I mentioned earlier. There definitely are people who have abnormal sperm DNA, at least in some of their sperm, but it turns out that most of the conceptions that have been studied where the guy was found to have some sort of abnormality in their DNA was not what led to the miscarriage. The thought is that if you have some sperm that are abnormal, they're probably selected out in the fertilization process and are not contributing to the miscarriage. There are some lifestyle factors to keep in mind. Cigarette smoking has been shown to increase the risk of miscarriage. Of course, smoking is bad for you anyway. You shouldn't be doing it, and especially if you're trying to get pregnant, and especially if you are pregnant. But there are studies that show that moms who smoke have a higher risk of miscarriage. That's also true for alcohol use and excessive caffeine use. So more than 3 servings a day of caffeine has also been shown to be associated with early miscarriage risk. Some of these situations we'll find something we can help, but about half the time you don't find anything, and it probably is related to one other thing that I didn't mention, and that's called microdeletions. So the actual chromosome, this thing, if you think of it as a chromosome, is all the DNA wound up into this. And it would actually, if you had little microscopic fingers, you could stretch it out, and then each one of these little ridges would represent a gene. And inside any one of those genes, if you just get a little bit of a loss, and this happens, you just lose that little fragment right there, like that, just that little bit. You lose that little bit of DNA out of your whole chromosome. The chromosome looks normal when you do the karyotype, but if you were to examine it at the DNA level, you'd find there's a little area of damage, and that's called a microdeletion. And there are a lot of microdeletions that have been identified that are associated with all kinds of problems, but one of which is recurrent pregnancy loss. You can test the products of conception, in other words, the placental tissue, the embryonic tissue, if it is passed by mom or if it's removed at a D&C. There are tests that look at the actual DNA and find these microdeletions. So if you have a patient who's had a completely normal evaluation, normal karyotype, everything's normal, a big chunk of those are actually going to be microdeletions. It can be tested. The problem is there's a lot of them, and some of them we don't really know if they're associated or not. There are some that are described, so genetic counselors will be able to help us to say, this particular microdeletion is associated or has not been associated. And on the flip side, if you had a patient who had multiple miscarriages and you had a couple different times where you tested with these DNA probes and found they had the same microdeletion, that would be a pretty strong indicator that that's a source of the miscarriage. So the thing about that is that you'll find that those people have about a 50-50 in terms of their reproductive history. About half the time they miscarry and about half the time they don't. And that basically comes down to if you get the chromosome that has a little ding in it and the DNA is missing, then they're probably going to miscarry. And if they got a chromosome that didn't have a ding in it, didn't have that microdeletion, then they don't miscarry. And so they're about 50-50 in a lot of those. You can do in vitro, and you can do DNA testing of the actual embryo before it's transferred back to the mom, and they can probe. If they know what the deletion is they're looking for, they can do the DNA probe and select the embryo that does not have that microdeletion, and that pretty much takes care of that problem. And there's a couple other things that I wanted to tell you. There's a study that came out recently that showed that the sooner you start trying again to get pregnant, the better your chance is for actually getting pregnant and taking home a baby. So take home baby rate. Low dose aspirin preconception could improve your pregnancy chances somewhat. That was called the EAGER trial. A low dose aspirin, that's 81 milligrams a day. So I do recommend everybody do that and start trying right away. So I hope that information is helpful to you. If you have questions, please feel free to put them in the comments. And thanks for watching, and have a great day.